Hello everyone, welcome to this video. We will be discussing the dermatology recall questions asked in the INI CET May 22 exam conducted just a couple of days back. I hope your exam went well and you were able to mark the questions to the best of your ability. As expected with this exam, the topics were repeat but the questions were twisted, slightly molded to give them a new look. But as I always tell you, repeat questions may not always be necessary, but repeat topics are a thumb rule that happens with these central exams. So never ignore these topics from the previous year questions. Always go through that topic, go through the options as well, and that is how you are best prepared for this exam and even for every other exam that you give. With dermatology, most of the questions were from the video lectures, were discussed amongst the grand test and the mock test that we have done, and I hope you were able to answer all of them. Now, coming to this question, this is a patient who has presented with a single hypoaesthetic patch with a satellite lesion, a thickened peripheral nerve. How will you treat? So what is the question telling us? Patient is presenting with a single hypoaesthetic patch. Whenever it is a hypoaesthetic patch, think of leprosy. So here, looking at the question, you know that you are dealing with leprosy. Now, in leprosy, we have this one patch here, which has a satellite lesion and one single nerve. So whenever there is a satellite lesion, what is the diagnosis? Satellite lesion, we have discussed repeatedly, is seen in BT Hansen's. So the diagnosis here of this patient is BT Hansen's, and he has a single thickened peripheral nerve. Now we come to treatment. So how will you treat this patient? Monotherapy or multi-drug therapy for 6 months or 12 months. So monotherapy is no longer used in leprosy. We always treat the patient with MDT, which is multi-drug therapy. So A and B, these two options are anyway ruled out. Now we have to choose MDT for 6 months or MDT for 12 months. How do you decide that? See, the basis of treatment is whether the patient is PB or paucibacillary or multibacillary. For the NLEP classification 2009, which we follow, even the WHO classification can be followed, but in India we follow the NLEP classification. So here, when the patient has 5 or less than 5 skin lesions, a single nerve or SSS negative. So these patients are classified as paucibacillary patients. On the other hand, when there are more than 5 skin lesions, more than one nerve, that is 2 or more nerves, and or a positive SSS, these patients are classified as multibacillary. So where does our patient come? Our patient has a single lesion and a single nerve. That means our patient is a PB patient. Now, as per the latest WHO guidelines, 2017, as per those guidelines, all patients of leprosy are treated with MDT, that is multi-drug therapy. PB patients treated for 6 months, MB patients treated for 12 months. So the same kit is given for 6 months to PB and 12 months to MB patients. So what is the correct answer here? The correct answer is option C, where we have multi-drug therapy given for 6 months to these patients. So coming to the drugs that I used, this red blister pack is the treatment for leprosy. This in itself is an image-based question, has been asked previously in the AIMS exams. And now that we only have this blister pack, there is no longer the PB kit. So this is an important question, and see, it has been asked now and multiple times in the last 5 years as well. So what do you have here? We have this monthly dose. In the monthly dose, there is a single dose of rifampicin, 600 mg, and clofazimine 300 mg. So these two are given as a single dose. As you can see here, this is rifampicin and this is clofazimine with this white pill, that is dapsone 100 mg. So these are given by the supervisor. This is supervised dose when the patient comes to collect the kit, and then the rest of the pills, that is dapsone 100 mg and clofazimine 50 mg, these are taken daily by the patient. Each kit is for 4 weeks. Okay, so this is the treatment that is given for these leprosy patients. As I have already told you, for patients who are paucibacillary, this same kit is given for 6 months, and for multibacillary patients, the same kit is given for 12 months. This 6 months treatment has to be finished in 9 months. This is an additional point. You should remember it, can be asked in subsequent exams, and this 12 months kit has to be finished in 18 months. Okay, so the patient can skip a month in between, but he has to finish these 6 kits within 9 months, and he has to finish these 12 kits within 18 months. That is how you treat a patient of leprosy. Okay, now coming to question number 2, again a question from leprosy. Here, what is the treatment of choice for a type 2 leprosy reaction in a pregnant female who's already taking leprosy treatment? So the points in the question is that there is a lady who is pregnant. She has leprosy, already taking treatment, now develops type 2 reaction. How will you treat? So mostly a type 2 reaction develops during the course of treatment. Okay, now what is the most important step? Most important step, continue MDT and start steroids. So as I told you, a type 2 reaction generally develops during the course of treatment. So they tend to give you this option, stop the treatment, because that is sometimes seen as the reason for development of the reaction. But no, you never stop the treatment. You always continue the MDT and start a treatment for the reaction. So here also you continue MDT and you add steroids. If you remember, the same question was asked in the INI CET exam last year as well. So this is a repeat question. Only difference is this time they have made the patient a pregnant female. Last time it was a type 1 reaction, and the concept that was asked was the same. Okay, so this is a repeat question. Last time it was type 1 reaction, what will you do? This time it is type 2 reaction with an additional twist of pregnancy. So with pregnancy, you rule out thalidomide. You anyway will not stop the treatment, and you will not even give azathioprine. So the correct answer here is continue MDT and add steroids. So coming to treatment of leprosy reactions, let us just discuss these. Whether it is type 1 or type 2, you will always continue the MDT. This is the most important thing that you have to remember. For mild reaction, treat with NSAIDs. For severe reaction, the drug of choice for both type 1 and type 2 is the steroid, that is prednisolone. So systemic steroids are the drug of choice for both type 1 and type 2 reaction. There are some additional drugs which can be given for patients with type 2. These include thalidomide, then a higher dose of clofazimine. Then we also have TNF-alpha inhibitors. There is methotrexate, azathioprine. So these are all some other additional drugs which may be needed for treatment of type 2 reaction. Thalidomide works by its anti-TNF-alpha action. And since this is a teratogen, it will anyway not be given in a pregnant patient. And it is also not the drug of choice. So this is not the answer when it comes to the first treatment. Thalidomide is only given in patients who are refractory to steroids or resistant to steroids. So patients who were earlier responding but now have stopped responding, or they do not respond at all. So in such patients, you give thalidomide. It is not the drug of choice. Drug of choice for both type 1 and type 2 is prednisolone. Then we come to this question, match the following: silver scales, Brani scales, colorative scales, and mica-like scales. This question I actually have given in one of the grand tests, and it is from there. So we also discuss this along with the different topics that we do. So where are silver scales seen? Very easy. Silver scales will be seen in psoriasis. So silver scales will be seen in psoriasis. Brani scales, again pretty simple. Pityriasis, versicolor. Colorative scales, everybody knows. Even if you close your eyes and just listen to dermatology lectures, somewhere or the other you will hear these words. Colorative scales seen in pityriasis rosea. It is only this pityriasis lichenoides chronica, which is a slightly new term, not often read by the students. Here you see these typical stuck-on mica-like scales. So even by choosing the other three options, you will come to the correct answer. So you may not know pityriasis lichenoides chronica, but if you know the other three options, you will still come to the correct answer. So 1 will be seen with D. So this is the correct answer for this question. Scales are quite often asked questions in dermatology. See this Brani or the furfuraceous scale that you classically see in pityriasis versicolor. It's a very fine, rough scale. So this looks like the bran from the wheat. Brani or furfuraceous scale. Then you have this collarette or the collar of scale, again classic in pityriasis rosea. I'd also tell you the signs which are associated with pityriasis versicolor scale. We have the nail scratch sign, or the Besnier sign, or the Coupe d'Ongle sign. So these are the clinical signs associated with pityriasis versicolor scaling. Then we have in pityriasis rosea a colorative scale. The sign that we see here is the hanging curtain sign. Then we have psoriasis, where we see these typical silver scales which increase, which exaggerate when you start scratching the lesion. The signs that are seen here are the Gretage sign and the Auspitz sign. And lastly, pityriasis lichenoides chronica, when you have these small stuck-on scales, which are called as mica-like scales. Some other classic scales are seen in seborrheic dermatitis, which are the yellow greasy scales, and ichthyosis vulgaris, where you have these fish-like scaling. Yes, there are multiple other scales in dermatology, but these are the important ones. And when you go through the videos, always make it a point to now more effort to remember the scaling, because once asked can be asked again. Coming to question number 4, a patient came in with the following lesion. He mentioned that a spider was crawling on his chest when he woke up. What is the diagnosis? So this is a very classic thing that the patients also tell you when they come to the OPD. Maybe the examiner made this question while he was sitting in the OPD, because almost every patient with this disease comes and tells you the same thing. कीड़ा काट गया, मकड़ी काट गया, ऐसा लग रहा था जैसे कीड़ा चल रहा था. So these are the things that the patients tell you when they come to the OPD. Now with the text, there is nothing that I can make out. Let us see the image. In the image, what do you see? In the image, you see that there are multiple grouped vesicles on a red base running linearly along a dermatome. So what you see here is multiple grouped vesicles on a red base in a dermatomal distribution. So this is what you see in the image. Now, when I talk about this image, or I give you this finding, what is the disease that strikes your mind? Yes, the answer to this is Herpes Zoster. because this is a very, very, very classical description of herpes zoster. Again, a very favorite topic for the AIMS or the CET exam. If you look at the questions from the last 5 years, you will find at least 3 to 4 questions, if not more. 3 to 4, I remember. The causative virus has been asked, the synonym shingles has been asked, then the treatment, the post-herpetic neuralgia, then varicella. So 5 times they have asked herpes zoster in the exam. It is such an important topic and a repeat one at the same time. So the answer to this is herpes zoster, where you see these grouped vesicles. If the question told you that the lesions were painful, that would have been a further confirmative hint to the diagnosis of zoster. Contact allergic dermatitis will not present in a linear pattern. That will be along the area of contact. Pedrus dermatitis is an insect bite reaction. Again, it will be in the areas where the insect has bitten, and the clinical picture will be different. Herpes simplex will not present in a dermatomal pattern. So even by elimination, you come to the diagnosis. Talking about zoster, this is caused by the varicella zoster virus. Question has been asked in the AIMS exam. Synonym is shingles. Again, it has been asked. And most common site is thoracic area. Lesions present linearly along a dermatome. When you make a Zank smear, oh, this is another time that they have asked this. Last year in the exam, they gave this question that the patient is presenting with this clinical feature. You do a bedside test. Which of these will be seen? So even though the classic finding is the presence of these multinucleate giant cells, there is additional finding of acantholytic cells. So acantholytic cells are also seen here. It is one of the causes of secondary acantholysis. So herpes or other viral vesicular disorders called secondary acantholysis. And the secondary acantholysis leads to generation of these acantholytic cells. So even though the classic answer for finding in Zank smear is multinucleate giant cells, but you also get a second finding of acantholytic cells. And this I've been teaching for the last many years. Question was asked last year in the AIMS exam. Okay, so one more way they have asked the same topic. So remember, in the bedside test, MNG and acantholytic cells, also called as Zank cells. And treatment of choice, acyclovir, given at a dose of 800 mg 5 times a day for 7 to 10 days. Okay. Sometimes a patient can have persistent pain, which is called as post-herpetic neuralgia. This is pain lasting more than 3 months. So the classic definition of post-herpetic neuralgia is 3 months, but mostly in the questions, 3 months is not written. They ask you 1 month. And even in the CET exam, 1 month has been asked. So remember, post-herpetic neuralgia is pain lasting more than 1 month. So this is about herpes zoster. You should also read herpes zoster ophthalmicus and oticus from ENT and ophtha. These again become important topics, especially the Hutchinson sign in herpes zoster ophthalmicus and the triad of herpes zoster oticus, also called as the Ramsay-Hunt syndrome. This is a picture of Pedrus dermatitis. I just put it so that you see along with it here. Even though we teach this in the regular videos, it is there in all my regular videos, but as an option here, you should see it along with zoster so that you learn to differentiate. This is also called as blister beetle, caused by an insect bite. The insect bite has a vesicant, which is called as pedrin. So this causes a type of contact irritant dermatitis on the skin. So this causes a type of contact irritant dermatitis, vesicles and redness, but only on the areas where the insect was. So this will not present in a dermatomal pattern. It will be here, localized area wherever the insect went. So this is about how Pedrus dermatitis looks like. This term should not look foreign to you. You should know what Pedrus dermatitis is. The last question here, and a new question. Yes, so this is a new one and a slightly difficult one, even though you may not have read this in dermatology, but this is generally taught in pediatrics. So I hope you were able to solve it with your knowledge about pains. A boy here presents with low platelet melena, means there is bleeding happening, and atopic dermatitis. What is the diagnostic investigation? What is the diagnosis here? When there is low platelets with eczema, you have to think of a syndrome which is called as the Wiskott-Aldrich syndrome. And in this Wiskott-Aldrich syndrome, the diagnostic test is looking for this WASP gene mutation, which is the Wiskott-Aldrich syndrome protein mutation. So this is the diagnostic test. No point looking for antibodies, no point doing a bone marrow biopsy or the IgE levels. A little detail about Wiskott-Aldrich syndrome. This is an X-linked disorder. Patients are males. So even in this question, it is a boy that is asked. So the patient is always going to be a male who may present with a classic clinical triad of thrombocytopenia that will be associated with bleeding diathesis. Our patient suffered from melena, then eczema, recurrent chronic eczema, and recurrent infections, which is suggestive of immunodeficiency. So this is the typical clinical triad with which the patient presents. When do you suspect? You suspect when any male patient presents with bleeding diathesis, thrombocytopenia, and microplatelets or a small platelet size. For diagnostic confirmation, you need to look for this WAS gene. Okay, so that is why this is the correct answer. You have to confirm the diagnosis with this mutation. So you have to look for this mutation. That is the confirmation. Treatment can be with IVIG, splenectomy, or a stem cell transplant. So this was a new question with respect to dermatology, but hopefully in pediatrics you have read this and that is how you marked it right. So with this we finish our discussion of these questions. Any doubts, you can put them in the comment section. You can ask them in the Telegram group. More than happy to answer. Work hard, study hard. All the best for your exams.